Hey guys, John Adamson, the Rehab and Documentation Guru. Doing home visits from my gas guzzling Suburban today because we had a snow during the night and into the morning. Beautiful, but couldn't get around in my old, beat up, but still very functional Toyota Avalon as safely as I can with this big Suburban with big knobby tires made for mud and snow and things like that. Want to do a video on two exercises that you really need to think about not giving your acute knee replacement. Number one, because they're aggravating, and number two, because they're redundant. And I'm talking about the infamous straight leg raise and supine heel slides. Both, one, incredibly uncomfortable. And I can say that with a great deal of assurance. As in 30 years of a career as a PT, I have seen countless total knee replacements, and those are the two exercises they routinely complain about. First of all, let's talk about the straight leg raise. What muscle are you primarily exercising with? Well, you are doing an isometric of the quadriceps. Now, obviously, that's an important component to knee rehab. I just made up a new word. Knee rehab. Getting a good isometric hold and extension of that knee is essential. Obviously, you need a good extension moment if you're going to have stability in gait. But they're already doing, and if you do them enough and with enough force, you will generate a lot of strength gain by doing just simple quad sets. There's nothing wrong with doing quad sets. They're excellent for circulation, for firing that quadriceps muscle that is limited post-surgically. And frankly, in our area, the surgeons do a lot of tourniqueting, and the thigh is deeply impacted from a pain standpoint and weakness standpoint because of the tourniquet effect more than the knee replacement. And in my humble opinion, seeing some of the knee replacements in the area that I work. So we're already doing quad sets. We're also doing seated for all our knee replacements, and I know you're doing it too, long arc quads, which are also addressing the quads. And then you get into more advanced exercises like mini squats, or I like to do simple sit to stands, which are far more effective in strengthening the quads than doing a straight leg raise. Now, what else are you engaging when you do a straight leg raise? Well, the hip flexors, right? So those are doing a concentric and eccentric contraction while the quads are doing an isometric. And you have to ask yourself, what value is that? For one thing, most acute knee replacements are having a hard time getting their leg up into the bed anyway. But that quickly goes away once the pain and the swelling start coming down. So one of the ways to improve the straight leg raise without exercising it is simply controlling for the edema, the inflammation, the swelling in the knee. Once you control that, the straight leg raise comes back anyway. It is a useless and very painful exercise for most patients. The other useless exercise, in my estimation, and most painful, is the supine heel slides. One, you just cannot get good range of motion in supine. It does not work out well for the patient. Two, like I said, it's very painful for most patients acutely. Why not instead just have them focus on one exercise that's usually given to them postoperatively, which is seated heel slides, much more comfortable than the supine. Yes, perhaps in supine you're engaging the hamstrings better, but again, the hamstrings are going to come back more naturally when you control for swelling and pain, and you're going to advance them probably fairly quickly to other hamstring exercises like standing knee flexion, which is going to engage their hamstrings quite well. So my advice to you would be to eliminate those two exercises. Your patient will feel more comfortable, and really what they should be focusing on acutely is range of motion to comfort, and I've talked about not cranking on your knee replacements, and two, elevating the heck out of that leg multiple times per day for a good while to get the inflammation out. Oh, and by the way, please don't make them elevate only on a heel towel. That is so uncomfortable to them. Yes, you want to prevent any knee flexion contracture, but I'll tell you what, you get that inflammation out, you get that swelling out of the joint with whole leg elevation, and they're going to get that extension back, no problem. Because under anesthesia, that doctor took them through full range of motion without any issues. Because if he or she couldn't do that under anesthesia, the doctor knew he or she had made a mistake and has to fix it right then and there. John Adamson, the rehab and documentation guru. Hoping you have a great day. Take care. God bless.